We're going to look at is the mental health continuum. So we know that mental health is not concrete. So it's not something we either do or don't have. We represent mental health on a continuum, so this thing here. And what we suggest, or what is suggested, is that although that there are degrees of severity from very, very healthy to very, very unhealthy, there's no clear-cut dividing lines between what is considered healthy or not. What this continuum is suggested to be is transitional. So what that means is that throughout our lifetime or within the year, we actually vary on this continuum from being mentally healthy to having a mental health problem to, God forbid, having a mental disorder. So what this can also show is the degrees of improvement after treatment and things like that. So what we're seeing is fluctuations. In terms of the mental health continuum, it's important that you understand the characteristics associated with each of these states: mentally healthy, mental health problem, and mental disorder. It's really important to know the characteristics in terms of the differences and whether you can apply these things to scenarios like we've done in class. So mentally healthy is a generally positive state of mental well-being, having the ability to cope with and manage life's challenges, work productively, striving to fulfill one's goals and potential, and having a sense of connection to others and the community in general. So what this means is that we have low levels of stress or distress. We cannot say we don't have any because that's unrealistic. We can cope with normal stresses, our behaviour is typical, and there is no dysfunction. In contrast, a mental health problem adversely affects the way a person thinks, feels, and or behaves, but typically to a lesser extent and of a shorter duration than a mental disorder. What we're seeing here is lower levels of functionality in relation to thoughts, feelings, and behaviours. There is some distress, maybe a little bit more than in a mentally healthy state. But this is generally as a result of a stressor like exams, a breakup, the death of a loved one. But once the stressor is overcome, these adverse symptoms should disappear. Again, in contrast to that, we have a mental disorder. This is a mental state that involves a combination of thoughts, feelings, and or behaviours which are usually associated with significant personal distress and impair the ability to function effectively in everyday life. So what we see here is intense distress. We see behaviour that is atypical. We see a dysfunction in thoughts, feelings, and behaviours. And we see the inability to cope with stress. Although we've just talked about the distinction between the three states, mental health problem, and mental illness, within the dot points, the VCAR study design suggests that you have to know the characteristics of a mentally healthy person. Now, again, we have talked about it, but on this slide here, you can see the explicit characteristics of someone who is mentally healthy. So we have high level of functioning, so being able to cope effectively with living independently in everyday life. So what we see is no or little dysfunction. We have social and emotional well-being. Now, these are different things. Social well-being is the ability to have satisfying relationships and interactions with others. So that's social. Whereas emotional well-being is the ability to control emotions and express them appropriately. So although they are kind of lumped together in one category, I want you to categorize them as different things. We also have resilience if we're mentally healthy, and that, as you will recognize, is a factor in maintaining mental health as well. So this is really important to know. Resilience, the ability to cope with and adapt well to life stresses and restore positive functioning. What this is not is the absence of stress. So what is suggested is that resilience is the ability to go, okay, well, I'm going to be stressed, but I know that I will be able to overcome that challenge. We know that if you're mentally healthy, there is occasional stress and mild distress. Again, it's really important that you know how to compare these with other states. and also identify these things in scenarios. Okay, the next dot point is ethics in mental health research. So we need to consider that most drugs and psychotherapies that are tested and that are used in real life situations have actually been tested on those who suffer from a mental disorder. Now, while that is ethically permissible, those who have mental disorders may be way more vulnerable to research, and so ethics committees have to take this into account. Now, in order to safeguard those from mental illness, there are explicit considerations that the Ethics Committee, or more specifically the National Statement of Ethical Conduct in Human Research 2007, outlines for those particular people. Now, in terms of the two specific things that they need to focus on that may have impacts on those with mental illnesses, we consider informed consent and the use of placebos. So we know that informed consent is the idea that participants can only participate if they've been informed of the rights, risks, and the procedure and have given their consent via signing a consent form or their parents and guardians if they're under 18. Now, we cannot consider any kind of research ethical unless participants have been given all of the information, have understood it, and have agreed to participate. The problem here, if we use people who are mentally unwell, is that a mental disorder may interfere with the capacity to give genuine consent. So what that means is because there are cognitive impairments, or there may be cognitive impairments, that diminish capacity for decision making, people who are mentally unwell may not actually realise the potential consequences of the research. So this point here is really, really, really important. This idea that people who have mental disorders, particularly those where there's psychosis, it means that they can't necessarily understand the rights, risks, and procedures and therefore give consent. Now, the way that the ethics committee kind of gets around that, or the way that researchers get around that, is by obtaining permission in 3 ways. So they can obtain permission from a legal guardian on the participant's behalf. They can outline to an ethics committee how they will determine the capacity of a person with a mental disorder can give informed consent and the ethics committee has to agree. Or they obtain consent at a time when a participant's symptoms do not interfere with their capacity to give consent. And then what they'll do is they'll say, okay, well, if you have a diminished capacity in the future when you are undertaking this research, what will you choose to do? Will you choose to continue with the experiment or will you choose to withdraw? Now, down the bottom of that informed consent column, you can see we have this here. Sometimes people are too unwell or too dangerous for themselves and the community to be left alone or to be not given treatment. Now, when this is the circumstance, what can happen is they can be placed under the Victorian Mental Health Act 2014, or they can be sectioned. And what that means is they are placed involuntarily into hospitals and they are involuntarily given treatment, regardless of what it is. Now, if they are sectioned, or if they are involuntarily placed into hospitals, it actually means that they can participate in any kind of treatment research as long as the ethics committee says that they can. So if a researcher obtains permission from an ethics committee to use people who've been placed under the Mental Health Act or have been sectioned, then that's perfectly fine, according to ethics. Now, our other section is the use of placebos. Now, we know that a placebo tends to be used in research to control for the placebo effect. So we know that what we would normally do is we might divide a sample, into 2 groups, or randomly allocate them into 2 groups. One group would be given the actual drug and the other group would be given a sugar pill, which is the placebo. And what is that's meant to do is control for participant expectation of how the drug will affect the person. The problem of using placebos on those who have mental illnesses is that the researchers may intentionally withhold an effective treatment. And what that can mean is that there is a possibility of the re-emergence or worsening of a mental health disorder. So that is really, really problematic. Now, again, this is ethically permissible if all other ethics have been upheld and a research committee or an ethics committee says that that's allowed. Over time, our placement on that mental health continuum, so this here, will actually vary depending on the interaction of internal and external factors. So when we consider internal and external factors, what we're actually talking about is the biopsychosocial framework. Now, that is an approach to describing and explaining how biological, psychological, and social factors combine and interact to influence a person's physical and mental health. Now, this is in reference to causation and to treatment, and we'll look at explicit factors for phobias a little bit later. We know that there are lots of examples, as you can see down in this table, and what we consider, or what it considers, is internal factors, so things that occur within the body, and external factors, so things that occur outside the body. The thing that you need to make sure that you are able to do is understand how each of these three factors interact, and how to identify these kinds of things from scenarios. The reason it's important that we know how these three factors interact is because the biopsychosocial framework is holistic. Now, what that means is that previously, physical and mental health were considered separate concepts. And so what the BPS model does is unites these because it considers the person as a unique whole that is influenced by these three factors. Linking to the BPS model is the 4Ps model. Now, the link is that these determinants, so the three domains BPS, can actually be divided into risk or protective factors. And it's actually really, really important to understand the difference between these two factors here. So knowing how they are similar and different is important. So there are 4 types of influences that contribute to the development and progression of mental health disorders. So each of these factors has a biological, psychological, and social perspective. So first off, risk factors are any characteristic or events that increases the likelihood of development or the progression of a mental disorder. In contrast, a protective factor is any characteristic or event that reduces the likelihood of the occurrence or reoccurrence of mental disorder, either on its own or when risk factors are present. Now, these risk factors can be further subdivided into 3 Ps. So we have predisposing factors, which increases the vulnerability of a specific mental disorder. So that's why me. And these are things like genetic vulnerability, personality traits, and disorganized attachment. We have precipitating factors, which triggers the onset or exacerbates the occurrence. And so that's why now. These are examples like poor sleep, stress, loss of personal relationship. And lastly, for risk factors, we have perpetuating factors, and this inhibits the recovery from a mental disorder. So that would be, why can't I get better? And examples of that are poor response to medication, rumination, and stigma. This model is really simplistic, but it's really, really important to understand and know how to apply these 2 scenarios. Now, later on, what you're going to have to do is understand how this whole model can be integrated with the biopsychosocial framework as well. Okay, the next little part that we're going to look at is to look more explicitly at the biopsychosocial framework. So what we're going to look at is biological, psychological, and social risk factors. So I've divided this up into 3 slides. So one's look at bio, one's look at social, one's look at psychofactors. And then later on, after we look at maintaining mental health, we're going to add them all together according to that 4Ps model. So, biological risk factors are internal, so they are factors that originate within the body and they're usually outside our control. So, they're outside control. Now, if you want an acronym to help you, you can use GUMS. So, we have genetic vulnerability, we have medication, we have sleep, and substance use. And that U is a bit silent. So just a hands-on acronym to help you out. All right, let's talk about the content. So the first thing that we talk about is genetic vulnerability. Now, what this means is that there is a risk for developing a specific mental disorder due to genetic inheritance. So what that normally looks like is if your family has a genetic predisposition, or if a certain illness runs in your family, it means that you're much more likely to get that illness because you have the genetic vulnerability. So it makes people more susceptible to certain conditions. However, it does not guarantee the onset of a condition. The next factor that we're going to look at is poor response to medication. Now, this is due to genetic factors. So what this means is that due to inherited factors, some medication can be metabolized too quickly or too slowly. Now, if it's metabolized too quickly, it means that the effects of those medication, the helpful effects that is, they will not have time to work on your system before they dissipate from your body. The other problem is that you metabolize those drugs or that medication too slowly, and what they can actually lead to is a buildup of medication and have serious side effects on the body. The other factors that we're looking at is poor sleep, and so we know that sleep is essential for replenishing the body and the mind, and we know that there is a bidirectional relationship between sleep and mental disorders. So what this means is that having chronic sleep deprivation may lead to developing anxiety or depression or things like that, or having a mental disorder like depression or anxiety, whatever, may actually be the cause of poor sleep. So pretty much what this means is that this is a really, really big risk factor, so it can be seen as a trigger. Oops, did it again. So a trigger. Lastly, we have substance abuse. Again, this is a trigger, so both poor sleep and substance abuse are precipitating factors. Again, the use of illegal drugs is bidirectional in so much as you can ingest some kind of substance and that can trigger disorder, i.e. schizophrenia, and having mental disorders can also lead to an increase in substance abuse in order to mask the symptoms of those kinds of disorders. However, this is really, really problematic because what it means is that it can actually interact with medications and make them less effective. So in this sense, it's actually more of a perpetuating factor. So psychological risk factors are also internal factors because they originate from within the mind. If you want an acronym to help you up, you can remember RISE. So that is rumination, impaired reasoning and memory, stress, and self-efficacy. So let's start with rumination. So rumination is repeated thinking or dwelling on undesirable thoughts and feelings without doing anything to change them. So this is a bit of a two-part definition. So we are dwelling on negative thoughts and we are not acting to change them. So this leads to mental illness in so much as it prevents problem solving, which increases feelings of hopelessness. And so that's why it is a risk factor for developing depression and other disorders. We also have impaired reasoning and memory. We know that we need to be able to reason so that we can consolidate and store memories that are realistic or are unbiased. If we have impaired reasoning, then it actually follows that we will have impaired memories. So if we have impaired reasoning, what this can do is it can contribute to the onset of a condition. However, holistically, these factors are perpetuating. So what this means is that it's actually harder to get better because we have impaired reasoning and memory. So the next thing that we're going to talk about is poor self-efficacy. So self-efficacy refers to a person's belief that they will be able to persist and succeed in accomplishing a goal. Now, if we don't have that, it will actually prevent people from dealing effectively with stressful situations. So, because they feel like they can't deal with those stressful situations, they tend to give up easily, avoid difficult tasks, worry more, and blame themselves for setbacks. So, what this will actually do, again, or it will continue to do, or it will contribute to the feelings of, is these feelings of hopelessness and lack of control over situations. And lastly, we have stress. So, stress refers to a state of physical or mental tension when the demands exceed the perceived ability for the individual to cope. So, we know through our work early in the term with gas that if we have consistent stress or constant stress, we have the prolonged release of stress hormones. Now, we know that when we get to that exhaustion stage, all of those stress hormones can lead to either a physical or a psychological breakdown. And lastly, we have social risk factors. These are external factors, so what they do is they interact with our internal factors. So the first factor that we're looking at is disorganized attachment. So attachment refers to the emotional bond which forms between an infant and a primary caregiver. This tends to occur in the first 12 months of life. So, attachment is influenced by how sensitive and responsive or responsible the primary caregiver is to the infant's needs, as well as the child's levels of responsiveness. If there is any kind of instability in the caregiver relationship, so things like physical distance, erratic behaviour patterns, emotional or physical abuse, then what this can lead to is disorganised attachment. So, disorganized attachment is characterized by inconsistent or contradictory behavior patterns in the presence of a primary caregiver. Now, while with the caregiver, if the child has this disorganized attachment, it can lead to them struggling to form a safe and secure relationship or experiencing a lower sense of trust in the caregiver. Now, this has implications later on in life. And that means that it can lead them to feel socially isolated, problems with parenting, problems developing strong relationships, managing stress, and controlling anger. So, again, what this will do is this will increase the risk of a mental health disorder. So, this is a predisposing factor. Now, as we talked about before in psychological factors, stress can trigger the onset of a mental disorder. Now, the loss of a significant relationship is a social example of that stress. So, it's a social part of the psychological reaction that is actually going to trigger the disorder or the onset of the disorder. So, we know that social support or good social relationships are a protective factor. So, when loss occurs, it results in significant emotional and behavioural changes. And if the grief is not dealt with properly, it can lead to ongoing anxiety and happiness. Now, the person doesn't have to die. It can just be like a relationship breakdown or someone moving away from, the residence or the school or whatever. Lastly, we have role of stigma as a barrier to accessing treatment. Stigma refers to social disapproval of a particular characteristic or attribute that sets a person apart from others. Now, in mental illness, often we stigmatize people as being crazy, or psycho, or dangerous, or whatever. Now, when people are labelled as being schizophrenic or having depression or anxiety or whatever, although they kind of get that diagnosis, alongside that comes this stigma. And so once you're labelled as having any kind of disorder, then you're more likely to be called crazy or psycho or schizo or whatever. Now, what can actually happen is when people are labelled and stigmatised, it leads to distress, low self-esteem, low self-efficacy, bullying and harassment. And so what this means is people are much less likely of seeking help and getting medication, and it actually makes them have a slower and reduced chance of recovery. Now, the thing that we have to consider about these risk factors is that they normally have a cumulative effect. So what that refers to, or what cumulative risk refers to, is the aggregate risk to mental health from the combined effects of exposure to multiple biological, psychological, and social risk factors. Essentially, what we're saying is the more risk factors a person have, the more likely they are to develop a mental illness. Now, this also applies to protective factor. So what we're looking at, I guess, is like a scale. This is my very bad example of a scale, between the balance of risk and protective factors. So what we would suggest, or what this model would suggest, is that if we have more risk factors, then we're more likely to develop a disorder. If we have more protective factors, then we're less likely to develop a disorder. Okay, so we've already looked at the bio, psycho, and social factors that contribute to the development of a mental illness. Now in this section, we're looking at how to maintain mental health. Now we also look at this according to that biopsychosocial framework. So we can slot that into the 4Ps model in the next slide or so. So the overarching thing we kind of want to talk about for mental health is this idea of resilience. Now, as we've talked about before, this is a characteristic of someone who is mentally healthy. So this is something, or this is the ability to cope with and adapt well to life stresses and restore positive functioning. This is something that is not innate, so it can be developed. And we know that it does not remove the stress, but it does enable us to cope better so we can function more effectively. When we discuss these factors here, the aim of these things is to enhance or allow us to develop this resilience. At this stage, it's important for me to note that with all of these factors, so the biopsychosocial factors, whether they be risk or maintaining factors, or protective factors, I should say, in terms of what you need to know for the SAC and for the exam, you need to know what they are and how they will either allow mental illness to develop or mental health to be maintained. So it's really important you know the how. Now, as a reminder, as always in any kind of SAC or exam situation, if you are seeing a scenario-based question, you have to make sure you are applying to the scenario. So with each of these factors, we can allocate them into the biopsychosocial. So a biological factor is adequate sleep and diet. So we all know what that is. Excuse me. What we need to know is how this actually improves or maintains mental health. So with our adequate diet, this can help to improve sleep, energy levels, mood, cognitive function, cardiovascular fitness, circulation, and a sense of well-being. The way that we can do this is to ensure that we represent all food groups, including vegetables and fruits, within our diet, avoiding things that are heavily processed with lots of salt and sugar, and minimising our alcohol and sugar-laden soft drinks. We should also ensure that we increase our water consumption. In terms of having adequate sleep, we know that this tends to be regulated by our age group. So for example, because you're adolescents, you should have about 9 hours of sleep per night. Now, if you do manage to have the amount that you require, it means that you should be less irritable, increase your ability to concentrate, and have more control over your emotions. In terms of social factors, we have social support. Social support refers to the network of family, friends, neighbours, and community members that are available during difficult times to provide emotional, physical, and financial assistance. Now, we've definitely seen those case studies where someone has had something physical happen to them, but because they've lacked social support, it means that they have been more likely to develop a mental illness. So we know that social support is a massive protective factor. The reason this is because this decreases a person's vulnerability to stress and it increases their ability to cope. Now, this is done through 4 different types of support, and it's really important that you know what these 4 factors are, or 4 types of support are, and know how to apply them to a scenario. So first we have appraisal support. This helps an individual to understand their mental health problem and identify issues. We have tangible, which is things that will offset physical hardship like money or foods. We have emotional support, which fosters feelings of reassurance and care that the person is not alone in facing the difficulties, and informational support, and this is helping to give information in order to develop coping skills. The last factor is psychological, and so these are cognitive behavioural strategies. So these are techniques drawn from cognitive behavioural therapy or CBT to identify, assess, and correct faulty patterns of thinking or problem behaviours that may be affecting the mental health and well-being of somebody. So what this aims to do is increase resilience so that the individual can deal with stress in their future or future challenges. So remember, we always have to go by the cognitive factors and the behavioural factors in this therapy technique. In terms of cognitive factors, we are identifying, assessing, and correcting faulty patterns of thinking and replacing negative or dysfunctional thoughts with ones that are more positive. So what they need to do is we challenge negative thoughts like I'm hopeless or I will never pass year 12 with more positive ones that promote self-esteem and self-efficacy. In terms of behavioural strategies, we are identifying and correcting maladaptive ways of behaving to improve mental health. What this tends to do is involve strategies or skills training that target specific areas. So things like relaxation, developing anger management skills, improving parenting skills, learning meditation, exercise techniques, developing social skills, all of that kind of stuff. So on this slide we can see each of those factors, both risk and protective factors, allocated into the 4Ps model. So we know that we've got the biopsychosocial factors, and each of those can be allocated into predisposing, precipitating, perpetuating, and protective. You need to make sure that you know that table quite well. Now, thinking about those cognitive behaviour strategies, one way that we can change our behaviour is through the trans-theoretical model of behaviour change. This model was originally made or constructed to explain the stages of recovering from like alcohol abuse or drug abuse. And so what it is all about is a stage-based model that describes and explains how people intentionally change their behaviour to achieve a health-related goal. So this model is a 5-stage model of change, and it suggests that people can go through stages gradually or at their own pace. The model emphasises that people change their behaviour in a way that's not necessarily linear. So what they're suggesting is that we don't have to go through each step at a time. And so what it suggests is that there can be setbacks and things like that, which kind of makes you like change up those stages a little bit, or it's not straightforward, I should say. One of the biggest things that is important to this model is self-efficacy. And so what they suggest is that people who feel like they can move on to a new challenge are going to be more likely to move from like each stage or the pre-contemplation to contemplation and vice versa. So you need to make sure that you know all of these stages. Now you need to know them in terms of the readiness for change, the timing of the change, and what kind of behaviour is being thought about or enacted. So is the behaviour overt or not? So the first stage is pre-contemplation, and in this stage the person is not ready for change and they have no intention to take action, within the next 6 months. Contemplation is when they are getting ready for the change, so they consider the pros and cons. They intend to take action within the next 6 months, but there is no change as yet. Preparation is when they are ready to make the change. So they intend to take action in the next 30 days, and they have taken some behavioural steps. Action is making the change, and so they have overt behaviour changes for less than 6 months. Maintenance is having those overt changes for more than 6 months. So you need to make sure that you know how to identify each of these stages within a scenario and apply them. Now, in terms of this model, you need to make sure that you know at least 2 strengths and 2 limitations. So you have the ones that you can see on the slide, but of course there are other ones that you can use. So the strengths are things like it's useful in understanding the process of behaviour change. It emphasises behaviour change as a process. It takes into account individual differences in people's readiness to change, allows for setbacks, it's based on empirical research, and it successfully predicts patterns in behaviour change. The limitations is that it lacks reliability and validity in so much as there is a lack of research. There is a limited usefulness in the design of treatment interventions. The model does not account for cognitive processes involved in behaviour change, and it may overstate the role of individual decision making in the change process. Okay, we are at the last little leg of the content. So our last thing that we're going to look at is stress, anxiety, and phobias. The first thing we want to consider is where stress, anxiety, and phobia lie on the mental health continuum. So psychologists believe that stress, anxiety, and phobia exist on the continuum, like the one that we looked at for mental health and mental illness. So in your notes, what you'll find is that continuum that is divided into those 4 broad categories: healthy, reacting, injured, and disorder. So it might be useful to look at where each of those things might lie on that continuum. So in terms of stress, we know that this is a state of physiological and psychological arousal produced by internal or external stresses that are perceived by the individual as challenging or exceeding their ability or their resources to cope. We know that stress can be a good thing, it can be a bad thing. Accompanying stress, there are lots of different reactions or symptoms that are cognitive, emotional, physical, and behavioural. We know that we can have acute and chronic stress, and they can be divided into eustress and distress. The main thing about stress is that it is something about that will give us resources to overcome a stressor. So accompanying stress are those fight-flight responses or those physiological reactions. Anxiety is a state of physiological arousal associated with feelings of apprehension, worry, or an unease that something is wrong or something unpleasant is about to happen. Now, like with stress, when we have anxiety, we are having a fight-flight response, or there is an accompanying fight-flight response, which should be giving us resources to overcome the threat. It's normal to experience anxiety in certain situations, and that tends to be when a threat is actually imminent, so when we can actually see that there is present danger. However, we tend to feel anxious for a limited time, and this is an adaptive response. So we feel anxiety so we can deal with those threatening, dangerous, or emergency situations. Anxiety can become problematic if it is severe and persistent, and it starts to interfere with normal functioning. And so if that is the case, what may happen is this may lead to an anxiety disorder. So an anxiety disorder is a group of disorders that are characterized by chronic feelings of extreme apprehension, distress, nervousness, or fear about the future. So again, the level of anxiety is so severe that it significantly interferes with daily life. An example of severe anxiety or an anxiety disorder might be if you were sitting on a plane and you felt afraid that something threatening could happen, but there was no actual evidence to support that feeling of threat. Unlike if you're on a plane, and the wings fell off. Obviously then you are able to feel anxiety, or you should be feeling anxiety because something clearly has gone wrong. A specific example of an anxiety disorder is phobias. Phobias are intense and irrational. They are characterized by unreasonable fear directed towards a particular object, situation, or event. We know that there are 5 categories of common phobias. So we have 1, blood injection injury, 2, animal, 3, natural environment, 4, situational, and 5, other phobias. So the really important thing that you have to do for this particular dot point is to understand the distinction, so not any similarities, differences, between stress, anxiety, and phobias. So I would like you to make sure that you know 2 differences between stress and anxiety, 2 differences between anxiety and phobia, and 2 differences between phobia and stress. So make sure you know those. Okay, so in this section we're looking at the biopsychosocial factors that have a role in causation in the development of phobias. So of course we're looking at biological factors, psychological factors and social factors. Okay, so let's look at biological factors to begin with. So we're looking at dysfunctional GABA. So we know that GABA is a primary inhibitory neurotransmitter in the CNS. So what that does is it makes the postsynaptic neuron less likely to fire. So when we have a phobia, it means there is dysfunction in GABA. So if dysfunction means a failure to produce, release, or receive the correct amount of GABA. Low levels of GABA make an individual unlikely to regulate anxiety, as their neurons may start to fire uncontrollably. Now, what this means is that their fight-flight response is able to be triggered more easily by a range of factors, or the fight-flight response is more severe. So this is more likely to predispose them to developing a phobia. Our next biological factor is the role of the stress response and long-term potentiation. So we know that those with a phobia experience the activation of fight-flight response that's more intense or more easily activated than the next person. Now this occurs when they either encounter the phobic stimuli or when they anticipate the exposure. So what this means is they may not actually experience the phobic stimuli, but what we're suggesting is that in either scenario, the stress response is excessive because it is out of proportion to the level of the actual threat. Now, whenever they experience this fight-flight response, so the one that is excessive because it's out of proportion, it means that they are associating fear with a particular stimulus, and new neural connections will form in the amygdala. Repeated exposure to that fear-producing stimulus will strengthen those neural connections, and so after that, they have really, really strong memories of that phobic stimuli being very negative. Okay, let's move on now to psychological factors. Our first one is classical conditioning and operant conditioning. So this is the behaviour model. So this is where those who are behaviourists suggest that phobias are all about learning experiences, and that's why we talk about classical and operant conditioning. According to this model, classical conditioning will precipitate a phobia, whereas operant conditioning will perpetuate the phobia. So classical conditioning will precipitate that because the phobias are a conditioned fear response. Now this occurs through the repeated pairings between the NS and the UCS until the CS alone produces the CR. In terms of the perpetuation via operant conditioning, this is when someone avoids the phobic stimulus. So when they do that, they feel a sense of relief. So this forms, or it acts as a form of negative reinforcement. So it increases the likelihood of the avoidance behaviour being repeated in the future. Now for that, remember we have to talk about A, B, C, as well as the negative reinforcement. For a classical conditioning, we have to talk about the NS, UCS, UCR, CS, and CR. The other type of model we look at in psychological theories is the cognitive model. Now, this emphasizes how people process information about the phobic stimuli. So we're looking at things like attention, memory, and all that kind of stuff. So the key assumption, according to this model, is that those with phobias have one or more cognitive biases. So this is a tendency to think in a way that involves errors in judgment and faulty decision making. Within the study design, there are two explicit biases that you need to know. You need to know memory bias and catastrophic thinking. So memory bias just means that the person with a phobia, they tend to recall negative information much more easily than positive or, I guess, benign information. So they're more likely to remember the frightening times associated with the phobic stimuli rather than the good times or times that kind of didn't result in any kind of feeling. The other type of bias is catastrophic thinking. So this occurs when an individual repeatedly overestimates the potential dangers of an object and assumes the worst. So it's like they see like a little kitten in the park or on the street and they think that like the kitten's going to kill them for some reason. Okay, now moving on to the social factors. So we have the specific environmental trigger. And so this is due to a direct negative or traumatic experience with an object or situation. So, what we link this to, in fact, is classical conditioning. So, that specific trigger may become a condition for your response through that classical conditioning process. And then it can be generalized to other similar stimuli. So, that's like, for example, with that video of the chick we watched, she was scared of the feathers. She had a specific environmental trigger when there was a bird let loose in her grandma's house, so she was scared of like that specific bird. But then what she actually did is she generalized that fear to all birds, including just feathers. The more severe the trauma, the more likely it is that a phobia will develop, but that's not actually always the case. The second thing we will talk about is stigma. Stigma. So we know that phobias often involve irrational and unrealistic emotions. And so people may apply negative stereotypes to that person, like if you scream every time you see like a little kitten, people are like, well, she's clearly crazy. So because people don't generally understand the person's reactions or the level of their fear, and they apply this social disapproval or stigma, it can lead to feelings of shame or hopelessness in the person. What results from that is the person actually hiding their symptoms, and this actually prevents them from seeking help for their condition. So this is really, really similar to just that general risk factor that we talked about earlier in the content. Okay, and lastly, we're going to look at evidence-based interventions in the treatment of phobias. So again, these are divided into biological, psychological, and social treatments. So for biological treatments, we have benzodiazepine, and these work obviously on that low GABA. So benzos are agonists. So what they do is they mimic the effects of GABA to reduce anxiety. Now they do that by making the postsynaptic neuron less likely to fire. In order to manage the elevated stress response or the overactive stress response, there are two things that we can do. We can use breathing retraining, and that involves identifying incorrect breathing habits and replacing them with more helpful ones. And so what that will do is that will result in lower heart rate, blood pressure, and stress hormones. It will also enhance energy levels and improve immune functioning. The way that this can normally be done is to help patients to learn how to breathe through their diaphragm in a slow and regular manner. The last thing that can be done is by engaging in physical exercise. Now we know what exercise does, and we know that there are lots of benefits to physical exercise through our studies in stress. So exercise helps to break down stress hormones, which helps to reduce anxiety as well as enhance our mood. Our psychological treatments are systematic desensitization and CBT. Now, both of these are a little bit more in depth in terms of what you need to know and your responses in comparison to the biological factors. So, first off, we know that systematic desensitization is a treatment that involves classical conditioning. Now, what it involves is progressively introducing the patient to the phobic stimulus using relaxation techniques until their fear is replaced by a relaxation response. Now, we do this using a step-by-step process. The first thing that occurs is the patient is taught a relaxation technique, which is like a UCS. This can be things like slow breathing, progressive muscle relaxation, and what that will do is that will produce a relaxation response, which is the second CR. The therapist will then break down the patient's fear into a fear hierarchy. And so that kind of puts the fear or breaks it down from instances or exposures that are least scary to the most scary. They would then expose the patient to the fear hierarchy. And so that's progressively, and that's a really important word, progressively, starting from the least scary to the most scary. So what will happen is the feared event, the CS, is repeatedly repaired with the relaxation technique, the UCS. After repeated associations, the phobia-inducing stimulus CS will produce the CR, the relaxation response. And then what happens is they work down that hierarchy until the whole kind of like fear response is replaced with a relaxation response. With classical conditioning responses, it's really important that you're always talking about those elements. So it's really important that you're always kind of talking about the CS, UCS, UCR, and all that kind of stuff. The second psychological treatment factor or intervention is CBT. Now, this is the most effective method of treating specific phobias. What it does is it uses a range of cognitive and behavioral therapies and learning principles to help people change unhelpful or unhealthy thought processes, feelings, and behaviors. The way it does this is through addressing cognitive things and behavioral things. So, in terms of the cognitive strategies, what happens is the person uses information to overcome irrational thoughts and replace them with ones that are more reasonable and realistic. So, explicitly or specifically to phobias, the patient will be forced to find evidence to support the fear and to refute the fear. So things like, well, how likely is it that a little kitten's actually going to eat me? Where is the evidence to support that? The behavioural strategies will modify the unhelpful and avoidance behaviours that have developed as a result of faulty cognition. The way this is done is through using relaxation training and things like systematic desensitization. Now again, for things like CBT, it's really important that you know the definition, the underlying assumption or the goal, and how to define and apply each of those cognitive and behavioral components. So it's really important that we are applying. And the last intervention is social. So this is psychoeducation. So this involves education about the mental disorder, so the nature of the illness, its treatment management strategies, and the role of support networks. It is for people who are affected by the phobia as well as their support network. And what it does is it aims to educate them about their illness and strategies to help them get better. And this will empower the individual to understand the illness and how to develop coping strategies. It also can actually break down stigma. The way it does this is through challenging unrealistic thoughts and not encouraging avoidant behaviours. Now, again, it's really important that you know the definition, the underlying assumption, what the descriptions for these two things are, as well as how to apply them to any kind of scenario. Now, lastly, we need to make sure that we know how each of these factors for phobias can be slotted into the 4Ps model. And so you can see that all here. So that is all of the content for Psychology 2017. Make sure you know all of these factors really, really well. As I've said before in class, this SAC is difficult in so much as it doesn't assess like big chunks of the content, but rather little ones. And so it's really important that you consolidate this information really, really well and do lots and lots of questions that help you to understand how to write responses.